The next session is Keynote Lecture 3. This session will be chaired by Dr. Osamu Yokosuka. Dr. Yokosuka, please.
Next session is Keynote Lecture 3 by Dr. Takahiro Kodama. And Professor Kodama is graduated from Osaka University in 2002, and he got PhD degree from Osaka University Graduate School of Medicine, and he studied from 2012 to 2016 as postdoctoral associate of Cancer Biology Program at the Methodist Hospital Research Institute. And he is one of the rising stars of hepatology in Japan, and he is today going to talk about title of his presentation is Biomarker-Based Precision Medicine in the Era of Combination Immunotherapy in SCC. Dr. Kodama, please.
Thanks, Professor Yokosuka, for the kind introduction, and it is a great honor for me to be selected as the presenter of this keynote lecture in a prestigious Oncology 2023. I also like to show my great appreciation to the Professor Ueno for this opportunity. So from this 20 minutes, I would like to talk about the review of the biomarker, basically focusing on the combination immunotherapy in HCC. So this is my COI disclosure. So in the first part, I would like to briefly touch on the basics of the cancer immunity and also mode of action and the efficacy of the two combination immunotherapy. And then I would like to review the current biomarkers for the HCC immunotherapy. Unfortunately, there is no good biomarker that reported in STRIDE regimen, so mainly the ICI monotherapy and also atezolizumab therapy. So you may see this slide many times here, advancement of the pharmacotherapy for the advanced HCC. Now we have the two combination immunotherapy regimens available. So this is a pivotal clinical trial result of the two combination immunotherapy, the IMLab 150, that is atezolizumab and the Himalaya STRIDE. Both regimens show nicely the significant superiority to the sorafenib by the OS. And based on these two clinical trial results, the BCLC treatment strategy, as well as other many guidelines, including Japanese one, are recommended atezolizumab and durvalumab as a first-line therapy, unless there is no contraindication to the ICI therapy. So when we discuss about the combination immunotherapy, it's important to understand the cancer immunity. So here's the player of the cancer immunity in HCC, the immune cells that are the cancer cells in the left-hand side, and also the protected cancer cells on the right-hand side. There is a very significant complex interaction shown there, so which makes us difficult to understand the cancer immunity. So I always try to focus on this cytotoxic T cell because this is the main player to kill the cancer cells. And this is also the famous cancer immunity cycle, basically explaining how the naive T cells are educated and kill the cancer cells. And if this cancer immunity cycle works properly, this means cancer immune surveillance is working on, so cancer cannot grow. However, cancer also cleverly tries to escape from this immune surveillance by producing a variety of the stimulatory and inhibitory factors shown here. And among these factors, now we can target 3 molecules, including the CTLA-4 and anti-VEGF and the PD-L1. So this is a mode of action of the atezolizumab therapy. Bevacizumab, the anti-VEGF antibody, basically normalizes the tumor vasculature, and the anti-PD-L1 antibody is atezolizumab, so blocks the PD-1 and PD-L1 signaling to activate the exhausted T cells. In addition, recently, anti-tumor immunosuppressive effect of the VEGF has been reported, including the inhibition of the DC maturation and also polarization of the M2 macrophages and activation of MDS and Treg. So blocks the VEGF signaling also affect a variety of the steps in the cancer immunity cycle. On the other hand, this is a mode of action of the STRIDE, a single tremor and regular interval of the durvalumab. Durvalumab is similar to the atezolizumab anti-PD-L1 antibody, and the tremelimumab is anti-CTLA-4 antibody, so primarily function to the priming phase. So what does priming phase do? So this is the priming phase in the lymph node. So antigen-presenting cells, such as the dendritic cells, present the tumor antigen to the naive T cell to get activated, and then turn into the effector CTL or memory CTL. So during this process, the CTL expresses CTLA-4 on the surface, and this CTLA-4 can bind to the CD80 and CD86 higher affinities than the CD28 to block the stimulatory signals. So when we apply the anti-CTLA-4 antibody, this can activate the T cells. So when we look at the mode of action of the two combination immunotherapy, they are slightly different from the perspective of the cancer immunity cycle. So if we can understand correctly which process is actually impaired in each patient, maybe we can better stratify these two drugs. However, it's not that easy. So one of the surrogate marker is a tumor immune microenvironment, status of the tumor lymphoid infiltration, so stratified into the immune desired and the immune excluded and the inflamed phenotypes, as so-called immune hot phenotypes. Now, I presented this data in this morning, but we performed this RNA and DNA sequencing and then in a resectable HCC, and we found 2/3 of the patient actually immune cold, probably which may explain why the ICI monotherapy is not that effective in HCC patient, and we need additional drug, the VEGF antibody or CTLA-4 antibody to further progress the cancer immunity cycle. So this is a response rate and the overall survival stratified by the response of two combination immunotherapy. You can see his atezolizumab PD rate is 20%, and the durvalumab PD rate is 40%. And then the patient with a PD response has a very poor overall survival. So this data clearly indicates that we need a biomarker to predict efficacy. So from now on, I would like to review the current biomarkers published for the HCC immunotherapy. So this is an overview of the source of the various biomarker candidate for the immunotherapy of HCC. So I would like to summarize one by one. So first one, I would like to talk about the tumor-derived biomarkers, including the PD-L1 expression and also tumor mutation burden. So this study evaluated the PD-L1 expression by the immunohistochemistry, looking at the tumor cells and also immune cells in atezolizumab-treated patient. And when you see if the positivity is stratified by 1% or 5%, there is no difference of the response. Only when we see the more than 10% of the positivity, it seems to be better in atezolizumab. However, only a few patients exist. So I think the PD-L1 expression is used in a clinic in a lung cancer patient. However, it's not that useful for the patient to predict atezolizumab response. So what about the STRIDE regimen? So this is a subgroup analysis of the overall survival in a STRIDE regimen and also durvalumab monotherapy. And you can see here, either PD-L1 positive or negative, there is no difference. So that means the PD-L1 expression is also not that useful to stratify the patient about the STRIDE regimen. So what about the tumor mutation burden? These are among the 755 patients. Only 1% shows the tumor mutation burden high in HCC patient. Nevertheless, when we see the low and the medium and high tumor mutation burden, there is no difference of the objective response and also PFS. So tumor mutation burden is used to choose the pembrolizumab in a variety of the cancer types. However, it's not that useful to identify the atezolizumab sensitive patient. So this is a specific tumor mutation in the tumor site. And most frequently mutated genes are TAR promoter and beta-catenin and p53. Now, as you know, beta-catenin mutation is correlated with the immune cold phenotypes. So indeed, actually, the patient with the beta-catenin wild type show the atezolizumab show better. However, when we see the patient with a beta-catenin mutation, atezolizumab seems to be similar to the sorafenib. So beta-catenin mutation may affect some in atezolizumab response. But this data should be interpreted cautiously because when we see the actual PFS value, the median values are very similar in all the cohort in the atezolizumab patient. However, when we look at the sorafenib, only this beta-catenin mutated patient have very long PFS. So probably this some bias. So indeed, when we look at overall survival, although in the absence or presence of the beta-catenin mutation, there is no difference. Both cases atezolizumab seems to be better. So this study focused on the Wnt beta-catenin pathway activation by the immunohistochemistry of the beta-catenin and the GS signaling from the Japanese group. Although the number of the samples are very few, however, the response rate and also overall survival are not different between the patient with or without beta-catenin signal activation. So taken together, I think beta-catenin pathway activation may not be the strong determinant of the atodobepa response. So next, I would like to talk about the molecular signature of the tumor transcriptome. So these are the gene expression signatures to predict ICI response, including the inflammatory signature for the nivolumab, and also interferon antigen presentation signature for the PD-1 inhibitors, and atodobepa response signature for the atodobepa. So we try to also validate these signatures for our cohort, and we found that actually ABR signature and also interferon IP signature are significantly higher in the responders. However, only the ABRS can stratify the PFS of the atodobepa therapy. Next, we would like to focus on the immune cells in the tumor immune microenvironment. So this study evaluated immune cells, especially the CD8 T cell in the tumor tissue by the immunohistochemistry. As you can see, the patient with a high CD8 T cell infiltration showed a better response in atodobepa compared to the sorafenib. However, in a CD8 low patient with immune cold patient, there is no difference. So these data suggested TIL existence of the TIL is a prerequisite to get the response from the atodobepa therapy. So nowadays, variety of the technology for the spatial analysis has been established, including the DSP and imaging mass cytometry and the Visium spatial transcript mix and also spatial proteomics. And some of the technology is already used to try to predict the response. So this is one study using the spatial transcript mix of the responder and the non-responder to the anti-PD-1 therapy. And then what they found is that non-responder has a significantly higher level of this red spot. This spot containing the SPP1 positive macrophages and CAF. So they claim that this interaction, this macrophage and the CAF is important to block the infiltration of the T cell into the tumors and mitigate the anti-PD-1 therapy response. So next, I would like to talk about the soluble factors. So this is a CRAFTY score, which is composed of the AFP and CRP levels. This CRAFTY score is originally developed to predict the patient overall survival when we treated with monotherapy, ICI monotherapy. And this Japanese group tried to evaluate the utility of this CRAFTY score in combination immunotherapy. And they nicely show that actually CRAFTY score stratifies the patient or PFS and OS upon the atodobepa therapy. So this can be used in a clinic. And we also tried to identify some of the plasma biomarkers to predict the response to atodobepa therapy. To this end, we performed the multiplex suspension array analysis for the 34 protein, and we identified high IL-6 levels were associated with a non-responder risk. And in a validation cohort, we successfully showed the patient with high IL-6 levels had a significantly poor response and also significantly shorter PFS and OS. Also, another serum biomarkers published from two Japanese groups, osteopontin and CXCL9. The patient with a high osteopontin and also low CXCL9 was associated with a poor response to the atodobepa therapy. Importantly, these two groups also evaluated these markers in the lenvatinib-treated patient, and on the osteopontin part, there is no difference. However, when we look at the CXCL9 high patient showed a poor response to the lenvatinib. So they claim that the CXCL9 can be used to stratify this lenvatinib and atodobepa treatment. This is an anti-drug antibody for the atezolizumab. Indeed, a substantial number of the patients actually developed the anti-drug antibody during the atodobepa therapy. And the patient with a high ADA levels, significantly lower level of the serum atezolizumab concentration. So as a consequence, the patient with a high ADA levels showed a significantly shorter PFS and OS in the discovery cohort and also validation cohort as well. So next, I'd like to talk about the circulating immune cells. To comprehensively search for the immune cell from the PBMC, they use the site-of technology from the nivolumab treated patient, and they identify the responder has a significantly higher level of the Tregs and CXCR3 positive CD8 positive effector memory T cells and APCs, and also significantly lower MDSC in circulation. And also they show that these immune cell frequency can nicely stratify the patient PFS upon the nivolumab treatment. And interestingly, these groups also try to identify the immune cells related to the IRA occurrence, and they indeed found a patient with IRAE showed a significantly higher level of the NK cells and also significantly lower CD8 T cells. So I believe this is the first study to identify the biomarker to predict IRA occurrence in circulation. And next, I would like to talk about the ctDNA. This is also our study. So we used cell-free DNA from the plasma of the 85 HCC patient who underwent atodobepa therapy, and we sequenced ctDNA targeting the 25 liver cancer genes, and we found most frequently mutated genes, the TAT promoter and the p53 and the beta-catenin. So we look at the association between these mutations and the therapeutic response. And we found in either in the presence or absence of the p53 and the beta-catenin mutation did not affect the response of the atodobepa therapy, which is consistent with the previous report. But interestingly, when we look at the TAT promoter, the patient with a TAT promoter mutation showed a significantly shorter overall survival. And later on, we found that these patients have the poor liver functional reservoir. So next, I would like to briefly talk about the gut microbiota. So this is a study for looking at the microbiota and also derived metabolite and also secondary bile acid for the patient with, treated with anti-PD-1 antibody. And then they show that the responder showed a significantly higher inverse Simpson on the Shannon score, indicating the high diversity of the microbiota. And also PCA component analysis showed a very different distribution and responder and non-responder, so microbiotas are different. Also, they found that some of the metabolites, such as the galactic acid and also arachidonic acid, are higher in the responder, together with the high level of the UDCA and UCA, secondary bile acid. So this data suggested the microbiota affect the ICI therapy response. So we try to evaluate the effect of the antibiotics use on the therapeutic outcome on the atodobepa therapy. And among the 105 patients, we found 19 patients used the antibody before the atodobepa treatment, so antibiotics before the atodobepa treatment. And then these patients showed a significantly worse, shorter disease control rate, and also poor PFS and OS, suggesting that we have to avoid the unnecessary antibiotic use before the immunotherapy treatment because it may affect the microbiota. Also, next, I would like to show imaging biomarker. This is again our study. We found that the steatotic HCC, which is representative of the tumor lipid deposition. And these cells, these tumors are 25% of the entire population. And these steatotic HCC showed a significantly higher level of the tumor-infiltrated immune cells and also T-cell exhaustion signature, and also upregulation of the variety of the immune checkpoint together with PD-L1 upregulation. So this steatotic HCC showed immune hot but exhausted microenvironment. And this steatotic HCC can be identified by the MRI chemical shift imaging shown here. And indeed, these patients showed a better response to the atodobepa therapy, showed PFS and also response. So these data suggested MRI can be the imaging biomarker to predict the atodobepa response. And lastly, I'd like to show you the etiology. So as you all know, that Nature paper showing the ICI efficacy is reduced in NASH HCC patient. And the follow-up publication from the Professor Lobet, they performed the meta-analysis of the 5 randomized control trial, and still non-viral patients show poor response to the ICI therapy compared to the viral HCC. So today I show the variety of the biomarkers currently reported in summary, including the tissue biopsy and also blood and the imaging and the medical record. In the future, of course, it is very important for the prospective validation. Also, as Professor Kao mentioned, I think it's better to use artificial intelligence, AI technology, to integrate multiple biomarkers to get more accurate prediction, which may contribute to the extension of the patient survival in advanced HCC patient. So these are my colleagues and collaborators. Thank you for your attention.
Thank you very much for your nice lecture. And is there any questions? Yes, Dr. Kato, Professor Kato.
Thank you, Professor Kodama. Great talk. I'm very impressed. But I'd like to know from your study or other literature, what we should do next for improving combined immunotherapy. I'd like to ask your opinion about it.
So thank you for the question. Experimentally, we have some of the biomarkers already published, but I have to say that all the biomarker is just a retrospective analysis, not prospectively validated. So, and I think in the future, of course, the prospective validation in appropriate setting is very important. And also, another thing is now we have the two combination immunotherapy, as I mentioned in just introduction. So I think it's most critical to stratify these two drugs, especially maybe atezolizumab looks better in a response. So maybe we need a biomarker to predict the response to the steroid regimen. And in that case, maybe we can perform the prospective the trial to using the biomarker. Actually, this biomarker can separate this patient, the survival when we use these two drugs. So I think this is maybe the goal, one of the goals. Yes.
Thank you.
Well, there's no time for further discussion, but any questions or comments? If no, I will finish this session. Thank you very much.
Thank you very much, Chair and Lecturer.